And we're continuing with our conversation on celebrating cancer survivors here who have successfully undergone treatment and have been cancer-free even for years. With me in studio is Sydney Chahonyo, he himself being a cancer victor, celebrating 19 years today. And of course, what an incredible story he's shared here tonight. We're also with Elias Meli, CEO, National Cancer Institute of Kenya, and Phoebe Ongadi, Executive Director, Kenya Network of Cancer Organizations. Phoebe, I'll start with you on this one. We were talking about the public not having or seemingly not having faith in our institutions when you start right from the misdiagnosis to the cost of treatment, people selling their property, taking loans to go to India for treatment. So medical tourism remains a big issue here, the exodus to India. Why India?
Thank you very much, Lilian Muli. I think one of the reasons why India is because of the diagnostics that they have. We have had very many stories of caregivers who accompany patients to India, and the caregivers themselves end up being diagnosed of a disease that they did not even know they have. So the level of suspicion index for the oncologists and the providers in India is, I think, one of the reasons. And another one is affordability. If you look at the cost of buying medicine in India, for example, compared to Kenya shillings, it is more affordable. But now we are looking back because there's a lot of strides that have been made. And the way Dr. Meli and ourselves are saying here, there is now better treatment right here in Kenya with sophisticated diagnostics that we could as well get in India. And one of the reasons why people go to India is also access and financial resources. So with social health insurance funds and all that, and of course, Kenya Network of Cancer Organization has been at the forefront of pushing for better healthcare, because all we do is just to get equitable access for patients who are affected by cancer or those who are at risk. So one of the things that we have really pushed and we are still pushing is for SHIF to stretch a bit, appreciating the strides that NHIF has done over the years, but even looking at now and say, can they just stretch a bit and accommodate diagnostic? Because we always say that early detection saves life. But what is this detection? You have to go for the diagnosis. And if just for a simple diagnosis, maybe will cost some money. So if you are told to pay for a diagnosis and then you have an option of buying food for your family, you will rather go for the food and leave alone the diagnostic. So later when the symptoms become more worse, you go back to the same hospital and probably the disease has spread out. So yes, we are saying that the exodus is in India, but what we are spreading today is that there is still hope here in Kenya.
Talking about these resources, Phoebe, can we get these resources in public hospitals in Kenya? And this is a question I'll direct to Dr. Meli as well. When you talk about the infrastructure, the skilled personnel that can actually, run these machines, we're talking about radiotherapy, we're talking about chemotherapy. So talking about infrastructure and whether these resources are actually available in public hospitals. We know that there's a huge waiting list in a lot of these public hospitals when it comes to cancer treatment.
I think before Dr. talks, there are strides, and we're really grateful for devolution. I think just before the show, some counties were calling me to say, we have now oncology center. Migori County was very clear and say, we are having oncology center that is coming up, and it's going to sort out all cancers. New specialists, like Dr. Meli was saying, have already been sent to that place. We have Kajiado County saying that now we are able to sort out oncology, because if there's a cancer patient in Kajiado, they will have to travel to Machakos or to Nairobi. And the distance between Machakos and Kajiado, or Machakos to Nairobi, is big. You can imagine the distance between Migori now to the nearest referral hospital, that is Jaramogi. So with devolution, we encourage devolution of these oncology centers, and with that specialization and availability at Mashinani, we are able to get in more people who would rather lack the fare to travel longer distances to access some of these cares in referral hospitals.
Away from the long distances, though, how much would this actually cost? Give us a hypothetical situation, leave alone the fare in itself. I talked about, and I know Dr. talked that, it's individual specific, so he really cannot answer that question.
Yeah.
But when we talk about the cost involved, what are we looking at?
We just, Lilian, the costs are over the roof. And I'll just give a very simple example what advocacy has done in cost. There's a drug called Herceptin that is used to treat breast cancer. And that drug, just getting a monthly supply of it will cost thousands of Kenya shillings. And I think I wouldn't know the exact amount, but all I know that through advocacy and lobbying, patients are now able to access. Another success story is what we call the CML medication. One patient per month will pay 1.2 million shillings. It is crazy. But with advocacy, we are having foundations that are coming in to support the government, to support the pharmaceuticals. And right now, with Henzo Kenya, supported by Kenco, and also Max Foundation, patients are able to access that medicine for free. And the success around that has been amazing. Yeah. So with access to treatment, survivorship is almost guaranteed.
Dr. Melly, Sydney spoke about, a drug that he very much needed that was not locally available. Talking about some of these being some of the challenges that perhaps might be leading people towards the India route, and now, I believe Turkey as well. Let's talk about infrastructure, available resources, even when you get down to, just the specialists themselves and the personnel that is needed, and whether we're seeing any improvement in that.
Thank you, Lillian. Allow me to demystify the cost issue between receiving treatment within the country and outside the country. If you look at the overall cost of cancer care, between traveling to countries like India and getting treatment here, if you compound it, ultimately, the cost of treatment here would be less. Why do I say that? Number one, if you are to travel outside the country, you are going to seek treatment that is available within this country. And the reason why most people would want to seek treatment abroad, a lot of it is more psychological. A lot of it is lack of trust based on long-time experiences which have been overtaken by events. Because right now, if they were worried 10 years ago that we do not have adequate capacity in this country, it is important that we, with evidence, with confidence, that we have built that capacity.
But we do not even have numbers on the survivors, on the survival rates, Dr.
Well, when we talk about survivorship, I would globally, we are a country that have put structures in place. And the turnaround time in our country is when the efforts of civil society and cancer experts more than 10 years ago, through Ministry of Health and the leadership in National Assembly, enacted a law, Cancer Prevention and Control Act. Because when you legislate through National Assembly, then you allow resources to be committed into, an area of interest. And this is how the National Cancer Institute of Kenya came to being, with all the attention and now committing resources that is going to go into cancer care in this country. So as we speak right now, we, with confidence, can share with you that we have more people surviving than before. If you were diagnosed with breast cancer 10 years ago, your chances of dying would be 5 times than when you are diagnosed right now. And it is because we are able to provide the treatment, and we are able to provide, similar treatment. And the approach for cancer care, as I mentioned earlier on, it is protocol-based. It is evidence-based. We cannot treat cervical cancer differently in Kenya from how it's treated in India. And I want to speak to specifics. You had asked earlier on about, the cost averagely. If you are diagnosed with cervical cancer today at stage 1, all the treatment that you need may be surgery. And surgery in a public facility would not cost you more than 300,000 Kenyan shillings. And that is adequate. But if you are diagnosed with stage 3 cervical cancer, where you would require chemotherapy, you would require radiotherapy, and maybe on a follow-up treatment, you may have residual disease and you got to do, salvage surgery. The cost will go to probably beyond 1.2 million. So as we speak about capacity that is within the country, today we are talking about hope. Today we are talking about survivors.
Yeah.
Sydney is here and many that we were with together during the day. So in our country right now, we have improved vaccination. We have a call to eliminate cervical cancer. And cervical cancer should not kill anyone in this country. No one should die of that. And it's only with vaccination. It's free, it's available. Now, we have improved screening. We are not where we want to be, and that is why we continue with this discussion of creating awareness all the time. We have improved diagnostics, but we can do better. And more often than not, previously people would want to go to India because of, nuclear medicine imaging. You may have heard about PET CT scan. That is what people would be like. If you go to India, there's a magical scan that you will, get to go through. It is now available in this country. We have 4 facilities in this country that are able to provide these nuclear medicine services. One is in public. So we have no reason, honestly, to go outside there. If you look at data for patients who went out to India for treatment in the past year, those who are leading in seeking treatment outside is cancer care. Compared to kidney, cardiology. And if you look at the cost that went into cancer care in the past financial year was in excess of 40 billion. This is a lot of money. And even when they go to India, interestingly, Lillian, they would still ask NHIF to fund. I have been able to refer a couple of patients whom I think they need specific treatment abroad that is not available here.
Right.
But most of those numbers have now reduced.
Right, and I want to cross over to Sidi, but before that, I want to talk about the health-seeking behavior, especially amongst men. You talk about screening being vital, but we are still experiencing reports, or rather we are still getting reports of men not being as receptive towards screening. And this is not specific to any cancers, but it's just generally the health-seeking behavior amongst men.
Well, I think this discussion about health-seeking behavior about men is not unique to cancer. I think it's how men have been cultured to be strong people, to trust that you can beat challenges. And with, creating a lot of education and awareness, I think information is being passed across now. And we are seeing more men being diagnosed with cancer, and not only cancer, even other chronic diseases, even other infectious diseases. They hardly present to the hospital early enough. Today, in our, Survivors Festival, we had 90% were women. They were ladies. Hardly did we see men. It's only Sydney and a handful of them, And if you look at also in terms of statistics, I mentioned earlier on that in excess of 44,000 patients are being diagnosed with cancer every year in our country. This is based on our data. And of the 44,000, 28,000 are women.
Yeah.
And it's because breast and cervical cancer are among the leading cancers. So you would also understand in terms of statistics that men would be diagnosed less compared to women. And that's why we have more women being, diagnosed with cancer, and we have more women surviving because they are also being diagnosed with, types of cancers that are potentially are curable. If you look at those cancers that, the incidences between men and women is almost the same, like cancer of the esophagus, colorectal cancer, cancer of the pancreas, liver, lung, that gender is not a factor. Most of those patients, unfortunately, the outcomes are not that great because we hardly have modalities to screen them. So what we are asking is build, capacity amongst healthcare workers to have a high index of suspicion, just like children as well. We cannot do screening for children. We would have to train the teachers in school, the parents at home to have high index of suspicion on symptoms so that they can be referred to centers. And this is a rallying call to men. We have been pointed out. Our healthcare seeking behaviors are wanting. So we are calling on you. Prostate cancer screening is available. And it is what we are now going to roll out across the country. Breast cancer, cervical cancer.
How are you going to make them receptive to this? Because most men feel that it is extremely intrusive and completely would not be comfortable with that. We've had people talk about, prostate cancer screening being extremely intrusive and men being uncomfortable with it as well, and having to take a little bit more convincing to convince them to actually.
So Lillian, we have actually made it, easier. We are no longer doing what we were calling DRE, digital rectal examination, as a way of screening in men. We are asking for a blood test. And more importantly, we are asking on the symptoms that the patient could be having that could be, talk about prostate cancer specifically, what we call lower urinary tract symptoms. Are you passing urine comfortably, or do you have hesitancy? Are you, waking up at night 5 times to 10 times? These might be signs of an enlarged prostate, but not necessarily cancer. So then this should point you to going to the hospital, get to be examined, get additional tests, and 1 or 2 may lead towards, cancer care. And I want to, at this point, appreciate a lot of our stakeholders, a lot of our partners. Recently, we have a program that we launched called Cancer Care Africa in partnership with AstraZeneca, and they've been able to support 7 of our public facilities with capacity to screen for prostate cancer. And these machines can also be used to screen for other different types of cancers. So we are going to continue with this rallying call, educate our people, let them understand the cost of early diagnosis is way minimal than the cost when you present late, which may include loss of life that you cannot recover.
Right. And Sydney, to you, going back to your treatment and the chemotherapy, people writing in and saying they've had horror stories or have even experienced, the same themselves. So in terms of your experience at that time, what support for you did you feel was extremely important during this season and during that journey when you were going through chemotherapy? And just walk us through whether or not it is in fact as intense an experience, painful sometimes for some patients, as most people are saying it is here.
In terms of chemotherapy, let me first say that for me, radiotherapy was worse than chemotherapy. For a lot of people, it's the opposite. As Dr. Melly said, you could have 2 identical twins that have the same cancer, but their treatment journey is completely different. Yes, there was pain. Yes, there was discomfort. Yes, I went through a lot, but also cancer is a very mental disease as well. I decided from the beginning when I saw a tear in my dad's eye, I'm going to be strong. I never thought of death, by the way. For some reason, I just said, I'm going to beat this thing. And that was my attitude throughout. Even on my bad days, I said, you know what, this thing is not going to bring me down. And even when I was feeling bad, I felt obligated almost to, even like when my parents would come and visit me in the hospital, to show them that, I'm strong, I'm doing well. So even on my very worst days, I would see someone walking in and be like, they're not going to see me like that. So that was one of the things. In terms of support, I don't think I would have made it through without my family, because cancer is a very lonely disease. I lost a lot of friends. A lot of people who started, spreading rumors out there. They didn't really understand what was going on. People are coming to visit to see if he's really going to die. And for me, if my family had not been around me, I don't think I would have gone through it mentally. So I'd like to appreciate my family, because without them, I would have not done it. I also want to appreciate my oncologist and the medical team and the nurses who are with me. My oncologist was very positive, and he broke down the information into bite-sized pieces that I could understand. He was not just talking in medical jargon. So I could understand, and he involved me in the treatment process. He told me, this is what we're going to do. These are our options. So that also made me relax. Aside from that, my nurses in the hospital became my second family, because as much as the doctor is the one who sees you and prescribes the medication and all that, 90% of the time in the ward is the nurses who are taking care of you. Okay. And they were also very positive. So I kind of had that support structure. As much as I'd lost almost all my friends, my family and, the medical team around me rallied around me. Yeah. And right now you find that in the cancer space, people rally around each other. You find a lot of survivors. I'm a survivor. I've been through cancer. I want to help people who are going through something similar to what I've been through. Right now, I'm working with an organization called Hope for Cancer Kids, and we support families from low-income backgrounds to get access to treatment. But what you find is that these people become family, because you'll go to the ward and all the mothers are, they're talking about their challenges. They have someone to relate to. Even the doctor who's diagnosing, you can't tell you on a scale of 1 to 10 what that pain feels like. Yeah. So the families rally around each other. They support each other financially in terms of giving them coping mechanisms, psychologically. And I really feel that without that support network and without survivors coming out to share their story, to give hope to people, and to walk other people who are going through cancer through that journey, then it becomes a very difficult thing to come through.
Thank you for that. Thank you for that. Phoebe, in terms of priorities for strengthening the national cancer response in Kenya, and just going back to a lot of people, talking about the cost of treatment once again, and, survival, of course, being very real in the eyes of many, but the expense involved also being a major impediment. In terms of, the Social Health Act and UHC now, do we envision that actually being a game changer? I know Dr. Meli has talked about the NHIF, previously allowing people to actually access treatment in India, covered by the NHIF. But in terms of now this being a game changer, looking at the situation we find ourselves in terms of the burden and the cost of treatment still remaining a real issue for most Kenyans.
Thank you, Lillian. I think one of the success stories will be the advocacy front. We see what advocacy has done by almost removing the cost of treatment for CML, and the success rates are pretty huge. So there are pharmaceuticals that are coming up, and we are lucky that this government is supporting them through KEMSA. And they're coming up to say, well, this is the cost of the treating this. We are willing to come in to subsidize it to this much. We'd like the government to come in and other stakeholders. So I will say that even before we mention social health funds, we could also look at other lobbying, other options of pharmaceuticals who are saying they're willing. Max Foundation is already saying they're willing to almost remove the cost of treating breast cancer in this country. And just to say that today, in the Survivors Festival, it was amazing to see how the survivor stories on patients who have gone through the tough treatments, on how that kind of support have made them survive through treatment. So with that kind of partnerships, the kind of advocacy and lobbying with the major pharmaceuticals and lobbying with the government to sort of remove some of these hurdles. And also we are saying that even a social health insurance fund is coming in to extend treatment to include the chronic illness. We are also urging them to think about the equipment, because you see some of these cancer treatments, they have like long-term disability in quotes for these patients. The patients who after treatment, they will have to be on stoma bags. And having a stoma bag is to ensure that the waste products are out. And a stoma bag is around 800 Kenya shillings in Kenya if you buy it directly from the pharmacies. So 800 Kenya shillings, you will need around one stoma bag every 2 days. So that means in a week, you'll have to spend almost 3,000 Kenya shillings just for that stoma bag. So, and during the COVID period, it was very desperate. We were seeing patients starving so that they don't have to get to use the stoma bag because of accessibility. So as we urge the SHIF to stretch a bit, we're also urging them to think of supporting some of this equipment that the treatment may have left for these patients that they have to deal with for a long time, like supplements and also stoma bags.
Yeah.
So,
Doctor, sorry, yes, okay. I'll let you respond to that, but just tying it to the question that I'm asking, again, the role of government, the Ministry of Health, other stakeholders to ensure that survival rates actually continue to increase. You're saying, perhaps a breast cancer diagnosed 10 years ago would have led to dire consequences as opposed to a breast cancer at level 1 that has been diagnosed in this day and age with treatment right here in the country. But you can, first of all, respond to or add on to what she was saying.
In addition to what Phoebe has shared with us, we are looking at cancer care from different perspectives. I'm always a champion of quality. And when we talk about quality, this is where the cost comes in. If you look at, you've mentioned again and again about the cost of cancer care. Earlier on, we referenced Herceptin. Before the Access program, this drug, which is a wonder drug, in particular, specific types of breast cancers, was costing more than 300,000 shillings. But right now, we have it at a cost of 33,000 shillings every 3 weeks, and it's courtesy of Access Program because of a lot of advocacy that has gone into this, and it's with partnership with Roche, which is the manufacturer. So when we talk about quality, we are looking at how do we get the correct diagnosis, because that is where the rubber meets the road. If we miss the diagnosis, then we will miss the entire downstream care for these patients.
Yeah.
And as we move into the era of treating patients with cure to survivorship, we have to make sure they survive and they live a quality life. You may want to ask, what are the long-term side effects of these treatments? You know, at this point in time, surgery has complications. Chemotherapy has complications. Radiotherapy has complications. But with new technological innovations in treatment, whether with surgery, because right now we are focusing into minimally invasive treatments. And this comes with a huge cost. We are looking at what we are calling interventional radiology towards both diagnosis and treating patients, where we may not have to do major, huge surgeries that are debilitating to patients. But then this comes with a cost. You are looking at radiotherapy. You know, previously we were doing non-conformal. When I say non-conformal, it was less targeted of treatment. But for us to target, you know, that specific area where the cancer cells are, with minimal side effects, we have to use technologies that are costly, that are expensive, and this is where the cost drivers of cancer care comes in. And if we really want to, you know, have equal outcomes with, you know, comparable to high-income countries that have invested a lot in Europe and in the US, we got to invest into this. And this is what we are rallying. As a country, you know, the government of Kenya, this current administration is committed through the National Cancer Institute of Kenya to make sure that as we improve health care in general, as we work towards universal health coverage, because you cannot treat cancer care with good outcomes if you have not improved the entire health system. You have to look at the entire health system. You have to make sure that we can properly diagnose, you know, common cold, malaria, diabetes, hypertension, for you to be able to rule out that this patient who is presenting with nose bleeding like Sydney is not just because of allergy, it is not because of other, you know, potential differential diagnosis, and it is now cervical cancer, postnasal space cancer or nasopharyngeal
Dr. Melly,
cancer.
I will come to you for your final thoughts. Sydney, somebody just asking, and please address this quickly as we start to wind up. Did you experience any complications post-treatment in the last 19 years? Have you experienced any post-treatment complications?
Thank you, Lillian. And the answer to that is yes. One of the things I experienced is that, as I told you, my saliva glands were compromised. Even now, I still have to, you know, when I'm eating, I still have to have a bottle of water nearby because, you know, they say that they never really go back to being 100%. My taste buds were also compromised. Now they're back, but as I said, it's not really 100%. A couple of years after, you know, going through my radiotherapy, I experienced long-term effects of radiotherapy, and I lost hearing. I lost my hearing, and which is why right now I'm wearing hearing aids. There's also the mental issues, the mental aspect of it. Every year when I'm going for that test, it takes you back to that point of, is it cancer, is it not cancer, even after 19 years. So there's a psychosocial aspect of it. You have people who lose their limbs and need to get prosthetics. You have people who have retinoblastoma, kind of eye cancer, and they have to get glass eyes, and they have to learn how to live, you know, in their new body, if you could put it that way. So there are very many long-term effects of cancer treatment. And at the end of the day, a lot of the time, they're not really addressed. And as Dr. Melly said, you should have a post-treatment plan. Now that we have declared you cancer-free, or now that you have reached this stage, how are we going to make sure you have the best quality of life? So these are some of the things that even with the new cancer control strategy, National Cancer Control Strategy, there's a section on survivors in one of the pillars, treatment, palliative care, and survivorship. So these are some of the issues that are now starting to come to the forefront, now that we are realizing that, okay, there are survivors somewhere out there. And survivorship doesn't start at the point where you're told you're cancer-free. It starts at the point of diagnosis. From the point you're diagnosed, you're a cancer survivor. So there are very many different long-term effects that people can have, psychological, physical, spiritual, even financial, because they say a cancer diagnosis pushes a family from poverty to extreme poverty, reintegrating back into the society. People are told, don't play with my child because they have cancer, and maybe they feel like it's contagious. So there's a lot of things that come with it. The stigma, the physical, the spiritual, and the mental aspects of dealing with life post-cancer.
Many thanks for that, Sydney. A message of hope to somebody who is dealing with cancer treatment now, to their family members, as we close with you. Just a message of hope to encourage somebody who can relate to your story as we close.
As I said, I'm celebrating 19 years of being cancer-free. Cancer is treatable with access to treatment. First of all, with early diagnosis and access to treatment, then the chances of you beating cancer are higher, which is why we need to do a lot of sensitization, primary healthcare workers, general public. But at the end of the day, to that person sitting outside there who has been told they have a cancer diagnosis, all I would say is this: be strong. Listen to your doctors. Adhere to your treatment, because you find sometimes someone will die not because the cancer was incurable, but because they were not able to follow up on the treatment. They were not able to stick to the treatment regimen, whether it's financial issues, whether it's issues out there about being told that it's a curse, misconceptions about cancer. So listen to your healthcare providers.
Yeah. Thank you.
Follow what they're telling you, and you would have a better chance of having a good prognosis.
Thanks for that, Sydney. To you, Phoebe, as we close as well, in terms of the National Cancer, rather in terms of the Kenya Network of Cancer Organizations, what support are you offering survivors today towards living, a quality life after beating cancer?
We are in honor of the May Mental Health Awareness Month. 2 out of 5 caregivers, Muli, who take care of cancer patients test positive for depression. So if 2 out of 5 caregivers who take care of cancer patients test positive for depression, it means 5 out of 5 of cancer patients at some point in their treatment journey will be depressed. So we are saying that as survivors, there are opportunities and avenues of joining support groups. And when we look at survivorship, 80% of the patients who thrive and who are fruitful with their journey tell us they have a support group where they fall back and share and come together. So as KENCO, we are riding on mental health this year, and we are also saying that let us come together and support these patients. As Sydney is saying, cancer diagnosis can take you from poor to very extreme levels of poverty. So we are calling stakeholders. Like today, we had a very successful food drive where partners came together and brought food for the survivors, and it was very happy because cancer takes away all the money for nutrition. Cancer takes away all the money for good health. So as that happens at KENCO, we are offering that avenue for our CSOs and our patients to access that food. So you can partner with us or any other person to do that. So we are saying access from the healthcare workers, have the information in the community, have the information. And just to finish up with the men, we are also doing what we call men-to-men peer, and we are calling all the sectors to come together, because the men will be in football clubs, they'll be in barazas, they will be in border shades. So we are saying we train those border people to reach out to the men, because we realize men do not easily open up when the women are involved. So we advocate for psychosocial care, and we are advocating for a holistic care for this patient, social, nutrition, psychosocial, and medical care to ensure utmost survivorship.
Daktari, as we close, Dr. Meli, holistic care for patients, for families as well that are dealing with a new diagnosis of a family member. We're talking about, income as well, it looking like, the richer you are, the better, off you are financially, then you might have better chances at beating this. So when we're talking about survival and offering hope to the people that, have watched this segment, what would be your parting remarks?
Well, Lillian, this is quite exciting that we are living at a time when we can actually beat cancer. And it is always devastating news when you break down information about a cancer diagnosis. You had Sydney mentioned that hardly do men shed tears, but it did happen to his parent. And this is routine in the clinic. When we sit in the clinic and we are breaking this news, we need a lot of support. And more often, we even have family who ask, please don't share with the patient the diagnosis, because they know the mental ramification these patients will go through. So we always provide that holistic, I would say, family conference, so that we are able to discuss with the patient, with the family, because the support system is the family. And we have caregivers who also need support, because they go through a lot of extreme distress when they see their loved ones going through a lot of challenges with treatment. And as rightfully said here, some of them even go into mental breakdown. So from the government perspective, we have appreciated that we have to be, invest also in a lot of counseling. We have to invest in making sure that this patient gets that holistic care. We have what we call multidisciplinary care for patients. So every healthcare provider, we have around 12 teams that are involved in taking care of this patient. It is not always about the oncologist. The oncologist is just a team leader, but there's a whole team of other healthcare workers who are involved in making sure there is better outcome. Finally, it is important to mention that, the success stories in our country is to vary the statistics that we began with. These 44,000 that we diagnose every year, and since these are estimates, they're even more likely to be higher. We would want, going forward in the next few years, the numbers may go up in the short term because we will be increasing our diagnostic. But in the long term, these numbers should reduce because we are focusing more on early diagnosis, and therefore the gap between, 70 to 80% of our patients, Lillian, succumb to cancer. 20 to 30, transits to survivorship. We want to increase the gap. Those who transit to survivorship, we would wish to reverse to zero. And if possible, let's have less people being diagnosed with cancer, and let's have more being treated with curative intention that goes into survivorship. And this government is committed through Ministry of Health and National Cancer Institute of Kenya.
Thank you so much for your thoughts. That is Dr. Elias Meli, CEO, National Cancer Institute of Kenya. We're also joined by Phoebe Ongadi, Executive Director, Kenya Network of Cancer Organizations, and Sydney Chahonyo, who has been cancer-free for 19 years. Also sharing his incredible story and offering hope to many others who may have been diagnosed with cancer, and family members as well who are dealing with the recent diagnosis of a family member. We are taking a very short break, and we thank you very much, gentlemen and lady, for joining us. We are back with more in just a bit.